we have a population of about 330,000 individuals that receive their care at Rees-Stealy. And every year we do a population assessment to see where our patients' needs are and see where our chronic conditions are that our patients are living with. And most of our patients are, by far, are living with hypertension. So right now we have 49,000 people living with hypertension. At the time that we started this program, we had 32,000 people, and that was about 4 or 5 years ago. So you can see how much it's growing. So we did not have a program, a specific program for patients with hypertension, and we really wanted to address that. So we were offered an opportunity to work with 9 other groups within the community of San Diego to work on cardiovascular risk reduction. And we jumped at the chance. And so these are our medical groups that we're competitors with in the market. But we all came together and we met on a monthly basis at least, and we really talked about cardiovascular risk and hypertension and talked about what each of the groups were doing within their organizations, and really came together and used the experts from our different organizations to come up with a plan and design a program and put protocols in place to be able to bring back to our individual areas and work on hypertension. And then we would come back together, and we still come back together every month and share our data and talk about what we're doing and what our successes are and where we've seen failures and how to move on. So MCG is our evidence-based guidelines. And many of the groups, Kaiser, Scripps, UCSD were some of them, and I think they all use MCG. So I want to say that at least half, maybe more, used MCG guidelines to base their evidence-based practice or their algorithms, right? What we put together, what we're going to talk to our patients about, how we're going to design our program. We needed evidence-based practices to do that as the foundation for what we're putting together. And for us at Sharp, MCG is really transparent to anybody in the whole organization. So we use it on a daily basis in population health, and our utilization management department uses it on a daily basis. But we actually have it so that the physicians and the clinic site staff can log in and get information from it too. And for us, for this program, it's the chronic care guidelines that we're using. When we first met together with the community groups on the problem of hypertension and cardiovascular risk within San Diego, our hypertension control within Rees-Stealy organization was about 75%. And what that means is patients with a diagnosis of hypertension having a blood pressure less than 140/90. So we were at about 75%, a little less, 74 point something. So when we put the algorithms in place and the program in place and started educating and working with our physicians and then coming around on the back end and outreaching to patients and using health coaching techniques, we were able to immediately get the patients or the cohort that we were working with up to 80% of control. And then by the end of the 3-year grant, our patients that we were working with, which was about 1,400 patients, a little less than that, I think it was 1,367, their blood pressure control was 85.7%. So we were really able to markedly, drastically change the control rate of our patients with hypertension. But the other exciting factor is we were only working with a group of about 1,400 patients, as I said, but it spread to the rest of the organization. So the total percentage of hypertension control at the end of the grant was 82% with our whole population. So that was about 40,000 people at that time. And even though we were only working with that small group of 1,400 people, we were using the techniques, and the physicians were using the techniques on all the other patients that they were seeing in their offices.
Wow, that's incredible.
So the spread is exciting.
Yeah.
So we saw we had a huge increase in medication adherence. So we were in the 70s or less than 70 even in statin use or statin adherence. And by the end of the grant, we were way up in the 90s. The medications that we looked at and that were part of the bundle that we wanted patients to have when they had a diagnosis of hypertension consisted of aspirin, statins, an ACE or an ARB, and thiazide. And what we found is we were in the 70s or lower for some of those medications, and by the end of the 3-year initial grant, or the work that we did, we had a 92% overall medication adherence rate. More important than that, why were we doing that? We were doing it because we were trying to prevent heart attacks and strokes. So we put a clinical effectiveness analysis together, and we wanted to look at our patient population before we started the grant, during the ramp up of the grant, and then at the end of the grant to see if we were really avoiding any heart attacks or strokes. And so we looked at those metrics, and we're still looking at them. The new ones haven't come out yet this year. And what we found that once the grant started ramping up, so between 2016 and 2017, by the end of the year, we found that we looked at patients per 1,000, and we found that about 47 less patients had a new diagnosis of a heart attack that already had a diagnosis of hypertension and had cardiovascular risk. And about 73 patients did not suffer from a stroke that year compared to the year before. So from the government CMS website and their statistics, we were able to take monies and put them to a cost savings algorithm. And usually when you have a new heart attack, there's about $70,000 a year that you would spend during that year of the heart attack with all the testing and the treatment and the hospitalizations or whatever is involved. And actually for a stroke, it's about $50,000 per year. So if you look at patients, 47 less patients had a heart attack and 71 less patients had a stroke, and you calculate that out, it comes out to about a $7 million of savings just because you prevented the people from having a heart attack or stroke. But more than that, it's about the quality of life and really seeing those patients and those families not having to suffer through those diagnoses and the hospitalizations and the quality of their life during that year. So that's the most exciting part about that.